Welcome, everyone. Welcome to the January HSPN monthly webinar for Ontario Health Teams. People are signing in fast and furious. Please now, if you could, go to the chat and tell us who you are. If you can let us know your name and where you're joining us from. We have instantly 150 people online. This is a popular event today. So welcome Steve from Kawartha Lakes, Seth from Kawartha Lakes, Monroe from UCCA, Rob Barnett from Muskoka and area, welcome. Karen from Guelph, and come Logan, welcome Logan Roy, Wendy, Jason from Rainy River, Rosie from Midwest Toronto, welcome. Great to see everybody joining us from all over Ontario today. Mike from Peterborough, Royanne, I think that was from Owen Sound, Tracy from Mount Forest. I have to keep up real fast here when I'm welcoming everybody to join us for this month's webinar. It's a real pleasure for us to be together today to talk about segmentation and how that can apply to your populations, and we'll use a couple of examples from the real world. Chats North York, Kaosang Phuntsok, welcome. Marjorie from East Toronto, welcome Marjorie, lovely to see you today. Okay, we will start with our land acknowledgement. I wish to acknowledge the land on which the University of Toronto operates, and that's where I'm speaking to you from today. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still home to many Indigenous people from across Turtle Island. We're grateful to have the opportunity to work on this land, and all of us today are joining from many parts of the province and the country, from traditional territories, and I welcome you to acknowledge the territory that you are joining us from today. See, people are still signing in. Naveen from AMHO, Diane Walter from Margaret's Toronto, welcome. We like to start ourselves off with a poll, so I'm going to go to the polls and open it up and see how many people we have here joining us for the first time. So let us know if you are joining us for the first time. I think that should be launched, although I don't see the responses coming in, so I will ask my trusty colleague Nusrat to send me a quick note when we have most of the people participated. Oh, there we go. I think maybe I had missed a click. Thank you, Nusrat. And people are fast and furious. They were just poised with their clickers. Over 150 responses in so far. 218 people have joined us so far. Welcome to our event today. And it looks like about 3/4 of everyone have joined us previously, and that's good staying power for us. We are very pleased to welcome you back each time and every time you join us. So now I will end this off. The results have slowed considerably now, and you will see that we have, as I'd said, 75% have joined us previously, but 46 out of 182 respondents, 25% are here for the first time. Well, you are in for a treat today. I'm very, very pleased today to be sharing. Oh, there, I think I shared them. Yeah, great. I'm very, very pleased to be joined today by Christina Clarke. Christina is a RISE population health management coach, working as part of the team of coaches to support Ontario health teams with their population health management strategies. For over a decade, Christina has been working in health systems across Canada and the US to support their improvement efforts related to better and more equitable population health, health system value, and experience. And Christina knows what it's like at the front lines. Often I'm speaking to you from about 30,000 feet. Today, we're going to try and take it down to 10,000 feet, make it a little more specific, but it's a real pleasure. My name is Walter Wodchis, and I co-lead the Ontario Health Team Evaluation along with my colleague, Ruth Hall, who is in the audience today, I'm sure. Today, we're going to talk about approaches to population health management. This is building on a series that we've been running over time. We're going to talk about what that means, and then talk about segmenting Ontario attributable populations as a key step in population health management. And I will talk about it from segmenting the entire attributable populations, and then Christina will talk about it from a subpopulation level as you get more close to actually implementing improvements in your teams. I'm going to give an example of looking at collaborative quality improvement measures by population health segments, and I think that's going to be relevant for many of you who are currently thinking about your cQIP measures and what plans you might be putting in place. And finally, then we're going to spend a good amount of time with Christina leading us through examples to connect segmentation to care model co-design and quality improvement. So without further ado, feel free to chat in the chat anytime along the way, and we'll try and stay appraised of that. Please make sure that when you chat, it is to everyone so that we can see it on our end and you're not just looking at it yourself. So what are we up to in Ontario Health Teams? So my colleague Rob and I wrote this opinion piece in Longwoods a little over a year ago, thinking about what does it mean to improve population health. And we actually say that improving value means both increasing population health and equity. And we're going to touch on both of those today. Again, when we think about population health management, you've seen both RISE, their Rapid Improvement Support and Exchange for Ontario Health Teams, and the HSPN talk about population health management. Well, we've come together now so that we can speak with one voice as we are essentially saying the same thing, and we'd like to depict it that way as well. So it starts with population identification, and that's that attributable population, and you may then segment that population for needs, risks, and barriers. Then co-designing person-centered care models and service mix, implementing those programs with reach and monitoring and evaluating according to the quadruple aim. And you're going to do this in increasing cycles of narrowing down to specific populations and then doing this entire activity within different segments or particular population groups. So for each time you pick a target population, maybe you have frail seniors, you're going to need to think about segmenting that population for needs, co-designing for each of the segments, implementing and reaching out across your programs for that. So this actually is a very iterative process. It's not a one-time event. We are thinking about, when you're looking at population segments, we started off with some indicators at the entire attributable population. Each OHT received a report back in the spring of 2021 to report on overall attributable population indicators for the entire population. And when we sent these out, we used these spider diagrams, and we said, you want to be close to the center, which was the best ranked Ontario Health Team in the province. We're going to be refining that approach in the next year, but that's how we started it out. And so you see here from this kind of an indicator, here's a team that is doing quite well on premature mortality and cost per month, but they were a little bit further behind on virtual visits and continuity of care. And we want to get these teams. And so how are you going to go about that? Because continuity of care for whom? In what populations? How do you think about wrestling and improving that when you may have 50,000, 100,000, or maybe close to 1 million people in your population? You really need to think, how are we going to enact those changes? And that's why, we want to make sure that we can refine this a little bit more carefully. So that was an example on the left with the overall OHT indicators. We also had indicators in mental health and addictions care. And here we had specific populations indicators. We also had them for frail older adults and people near the end of life or palliative. So out of here, 2 of these indicators have been raised again as cQIP measures for OHTs in 2022-23. That's the ALC indicator, and ED is a first point of contact. And to this, there have been 3 new indicators around recovery, and these are around cancer screening indicators, mainly motivated by the fact that we are very concerned that during the pandemic, there's been a lack of contact with many of the people out there, and as a result of that, we've seen drops in cancer screening rates, and that may lead to further downstream issues. And so I'm going to go through some of these examples today and talk about population segmentation and these particular indicators. Here, I'm going to go to a poll and ask you folks if you've been thinking about using your cQIP indicators. And the first thing, how have you used them? Hopefully accessed through the Ontario Health platform. And so we'll put this out to see the extent to which you have used these indicators. There we go. Okay, so here we go. How have you used your cQIP indicators? You have not yet reviewed them. Your project management office has been reviewing them. Maybe you have a performance committee, maybe you don't. Has your leadership group discussed the data? Have you started to develop your plans? And have you drafted new plans? So how far along are you in your planning? So people are coming in with their responses now. Wow, we are a popular event today, Christina. It must be because you are here. We have 270 people online. It's a real pleasure. I do see people are still responding. We'll give a few more seconds and it's slowing down. I think we're going to get just over half the respondents. Everybody may not be directly taking part in the discussions with their OHTs, and they may not be fully aware. Yeah, HSPN has not sent out indicators. These are ones that have been made available through a collaboration with ICES and Ontario Health to make them available to Ontario Health teams. We've waited for them because they'll be the official keepers of the indicators. So I'm going to pause it and then we'll share out the results. And I'll need help sharing out the results so that everybody can see them. So we see that a quarter have not yet reviewed the cQIP data. We see 33% or a third say the project management and backbone team have been reviewing them. The performance committees discuss them about another third of the time, and the leadership group has discussed the data also about a quarter of the time, starting to develop plans for the cQIP 40%, and drafting plans, 6% of people have already got some draft plans in place. And so there, hopefully you can all see that now. I am going to rely on other Nusrat on the line to help us to make sure that you can get to see these results, because I don't seem to have control over that part. Okay, and I have one more poll here that I want to know, and specifically I'm interested in which of the indicators have you put your most focus in so far. So here's the next one, on which indicator have you advanced the furthest so far? Alternate level of care, emergency department, and perhaps some of the cancer screenings, mammography or cervical or colorectal. Which ones? So we see that people have been working at it in the prior, and it's good to see that people are using it in, I could tell from that, multiple different parts of their OHT groups taking a look at the data. And now it seems that the leading, we're having a close tie between ALC and emergency department. I'll leave it open to see who breaks the tie here. It is a dead heat at the moment. And with a few others still just beginning to look at the data and plans. Okay, so I'm going to share these back out. And so you see that about half of everyone has just begun to look at the data and planning for your goals. And then about a quarter in the ALC and emergency department for mental health and addictions. And that may deal with also the populations that you're looking at. So if you have frail older adults, you might be more likely to be looking at ALC if you've picked mental health as a population. And I think these cancer screening ones are fairly new to people, may or may not. One of the things about the screening, though, is that it applies across your entire population in many, many different segments. And it's a bit of a population health approach. So I'm a little favorable to the activities that you're going to do, and we'll talk about how that's going to happen, that you're going to have to think about in order to advance the screening indicators and taking a population health approach. So now I'm going to ask you to talk in the chat a little bit. And for any of the cQIP measures, have you thought at all about different subpopulations that you might want to focus on for improvement? Have you started to think along those lines? And I am. Coming back up, there are some technical questions about the first point of contact. And so for the indicators that OH produces, they have technical specifications for those indicators. And rather than say anything that I might mistake anything, I'll refer you to the OH, the Ontario Health platform, where they have the technical specifications for these. And for our part, people asking if we've sent out the reports, we will be sending out some of the results that we're talking about today. We want to share them with you, get some feedback, and then we'll start sharing them out with the teams next month. Okay, so now here we go. Talking about some of the conversations. Marjorie says, yes, focus on one or more neighborhood improvement areas in Toronto. So thinking about neighborhoods as subpopulations. Sarangan had said that some of the conversations our group have had about how our priority population is frail, but the preventative measures may not be appropriate for them. Yes, and we're going to talk about that, because I think that when you are frail and old, and perhaps even in long-term care or heading towards the end of life, maybe the screening indicators are not the most. And so you might want to think about both focusing on populations, but then also maybe not focusing on some populations. So by choosing some, you may be providing less focused on others. Robert Barnett suggesting that relevant age groups, geographic breakdowns in clinical, major clinical categories, I think MCC, I'm guessing, as we begin to identify target groups for ALC. So people are thinking about this, and I'm really, really pleased. Karen Armstrong thinking about rural populations for ALC. It's a different, thinking about solving it in a rural area is different than an urban area. So I commend you on that. Mammograms, women living in subsidized housing. There are a number of OHTs thinking about some specific areas or congregate settings sometimes. That actually can be a very efficient way about working on improvements, because sometimes those congregate settings have some high needs patient populations. Melissa Sharp-Harrigan, who's been a guest here before, our OHT has discussed how the cQIP strategies for improvement will be grounded in equity and may be different for those attached to physicians versus unattached to primary care. I'm going to have some little treats at the end for you. And cancer screening of unattached patients. Yes, that's going to be a challenge. And I'm going to, let me go ahead now, because I think people are sharing in some really interesting results, some commonalities and some differences. And Sabrina Peluso, I'm hoping that we'll be able to help you out a little bit, along with others. So how does today build on work? So keep the chat going as much as you want. So people, you're sharing this information, and it helps other people to see how different OHTs are working on this. We're building now on prior HSPN, both the white papers on population health management, and also in February, we had a webinar talking about those. And some of the key recommendations coming out of there was, first, that Ontario is rich with linked population clinical, administrative, and claims data. We are missing data, but we do have a lot. And how Ontario health teams should consider both data-driven risk stratification approaches and more clinical heuristic population segmentation approaches. And we talked about this previously in our September webinar, and I'll allude to that in a minute. And to think about the relative merits of each and the potential for a transition to a needs-based approach to care. And the purpose here is to ensure segmentation can support that next stage in population health management. Segmentation is good, but it's not done for its own purpose. It's really done in a way to help you co-design person-centered care models. And I talk about that in abstract ways, and Christina will talk about that in much more concrete ways in just a few minutes. So we're going to take it down a level. Previously, we were reporting from the entire attributable population, and now we're going to talk about talking about subpopulations and using population segmentation to identify patient populations with, albeit for now, crudely similar health and social care needs. And oops, there was something on that slide. And moving it, today we're going to use the British Columbia Health System Matrix as our example for how to undertake and use population segmentation. And you can use other approaches, and we'll be back talking more about CIHI's Pop Grouper. We did talk about that in our September webinar. In September, we talked about the CIHI Grouper and the BC Health System Matrix. Deborah Chen was here from CIHI, and Sam Magnus from the BC Ministry of Health. I recommend you go back and have a look at that if you didn't see it, because it really talked through those two different systems and how they complement, but are also a little bit different. Here, we have the population pyramid. So one of the things about segmenting is we're thinking about segmenting the population into these different needs, risks, and barriers. So at the bottom, the bulk of the population, most people are going to be fairly healthy and mostly healthy and hopefully becoming healthier. And then you have people who have a rising risk to become more medically complex or a high-risk individual. And you have to think about different strategies for these different groups. And maybe, minor illnesses or preventative care needs primarily in those healthy patients, and moving up through ongoing illness or multimorbidity and frailty to very complex needs at the end of life, and thinking about different services, more care management and coordination needs as we get to higher up in the pyramid, greater health risks, barriers, and medical complexity as well. And this is another one of these pieces of material where we're messaging the same way as RISE to help advance the Ontario health teams. Across the board, we need to think about social factors and equity issues, regardless of health status. And that's something that's bringing that equity lens to every different place. So let me describe in a few slides the BC Health System Matrix, and then I'm going to apply it to your Ontario health team populations. You'll see what I mean. First off, the British Columbia system is largely clinically driven, and it was initially developed to predict care service needs, and based on the Bridges to Health model, which was first written about in the Millbank Quarterly and talked about some work out of Hopkins and some other colleagues thinking about using population segment to provide better healthcare, and that's its motivation. And the way they ended up categorizing people was on the far left, the broad category was the needs, either staying healthy for many, most, getting better for some, living with chronic illness and chronic conditions for others, and then towards the end of life, or more sustained palliative approaches to care for more frail and complex populations. And then they have more specific segments, 14, they're shown in the middle, and then a little bit about the needs and what kinds of services might be used and how we sort of define those individual groups shown there on the far right. And so this is taken from the BC documentation on the BC Health System Matrix. So we applied that to this chart, and whoops, color changed there and moving to this platform. You see that the healthy or low users and non-users in that BC group, they crime on the far right, you see 39% of the population and 11%. So more than 50% of the population are in that healthy group. We also report here spending, and we've reported previously in our indicators what the total spending is, and also premature mortality. So we're taking that overall OHT number that you had before and showing what it is and how it varies across these different segments. So quite low spending in those low user groups and very few deaths. And as we move up, you see medium chronic conditions in the second group up, maternity and healthy newborns, low chronic conditions. They're kind of a middling group, relatively low cost, premature mortality, still on the lower end. And you see they're comprising about 40%, just over 30% of the population in there, in that group. And as we rise up, the populations get smaller and smaller, but they also become more complex. We're spending more money on them, and you know, complexity leads to premature mortality as well. So you see, this is one way of looking at how the pyramid is applied to the specific population and how that ranks out. So now I'm going to look at, I said I come back to these indicators. Within those different segments, and this is really where we wanted to go with it, we're going to report on those 5 cQIP indicators: ALC, mental health first, the 3 cancer screening indicators. We'll be sending you reports in the OHTs on the cQIP indicators, the same calculations provided by Ontario Health. We're providing the same calculations, but now divided out into these different groups, both using the BC system matrix, and you'll also get it by CHI. Today, I'm only talking about BC to keep our conversation focused and simple. You'll see that different indicators are prominent in different groups, and that makes sense. You were talking about whether cancer screening was relevant for the older populations, and you might think that ALC really isn't going to appear very often in the healthier populations, for example. So let's see if that bears out. And I think if it does bear out, then this set might be a bit useful to us. So here we go. I'm going to start out looking at ALC days. I'm going to pause for a moment on this chart. You're going to be getting these charts for each OHT. The data here represent the entire population of Ontario. You'll see it for your own OHT. You see at the top the non-users. The dark blue represent the number of inpatient days by people who were previously non-users. So the definition of non-user for us is you didn't use healthcare in the 2 years prior to 2020, but then some of those people do. And then the ALC days is a bright green. So you see in the non-users, you know, they're not using a lot of hospital days in general, and very few, 7%, become ALC days. Similarly, in the healthy population, but even fewer there have ALC days, or proportionately fewer have ALC days. And so what the total bar length means in this graph, how many days in hospital each population group has contributed, the dark being the non-ALC or regular acute days, and the green being ALC. So you'll see that proportionately, if we go down the list, high chronic and frail individuals, people with frailty and high chronic conditions, but still living in the community, they have 34% of their hospital days are spent in ALC. They also have the most total hospital days across all of Ontario, contributing over 1 million hospital days in that particular group. And you'll see, actually it's 10 million. And so this chart allows you to see how many total days, and then also the ALC rate. So the overall average in Ontario for the entire population is 18%. And you can see that that high chronic frail, they are well above the average. People near the end of life, palliative patients, also proportionately higher. And people coming out of long-term care homes, also proportionately higher than the provincial average in terms of proportion of days in ALC. And you might think of different strategies or different patient needs that these different populations have. I'm going to go on to the next, which was mental health related ED visits. So here you see that people with low chronic conditions have the largest number of people, and this is now the number of people with a mental health related ED visit who previously did not have a diagnosis of a mental health condition. And so the most events are in the low chronic conditions in terms of presentations to ED for mental health, and 23 per 100 of those previously had no contact or no diagnosis in the community. And we see in the healthy population, also higher up there, those people who we really weren't paying much attention to perhaps, their mental health needs, and they were encountering the health system, but proportionately, they have a high proportion with the first contact is in the ED, and we missed their condition, their mental health condition, when they were living in the community. So these point to some of the strategies, and then we also see that a lot of ED visits do occur for mental health with mental health and substance abuse, but obviously very few of them are having their first contact. And you'll say, how could any of them have their first contact? Well, that deals with a definition in that we put you into a category based on your healthcare use in the past 5 years, whereas this indicator only captures the last 2 years. So previous to showing up in the emergency department in the 3 years prior, we did know that you had a mental health issue. So again, you're seeing here different populations. You see very few in the older adults, the cancer population, the end of life group. They're not prominent here the way they were in the ALC indicator. So this is providing a different view. Okay, on to cancer. So here's the breast cancer screening rates for all of Ontario. And you see there who is screened versus not screened in each of the population groups. And again, the overall provincial average is 49%, which is down considerably from the prior years. I think our numbers are showing that they're down by about 10% over prior years. And you'll see that the screening rates are, for the non-users, people who were not encountering the health system, only 7.9% of that population group are current on scanning their screening. And that makes sense because no one has reminded them. They haven't seen anybody in the health system. And then we also see that the largest number are still also among the healthy or people with low chronic conditions, followed by people with medium chronic conditions. So those medium chronic conditions people, they are in seeing both primary care and specialists, whereas the healthy people probably mostly see, well, I can say about 66% only see primary care. So we might think about who is going to reach out to people and help them. These look quite similar across the different screening indicators. So on the PAP screening, again, this is a wider population group now. And as a result, our denominators are much larger. The number of people is that number across the denominator. But which population groups show up, again, are similar in the healthy, low chronic conditions and the non-users. Again, you see further down the list, people with greater degrees of frailty, even if they have fewer screening, fewer are eligible or require screening in those older population groups. And so this indicator only counts people up to age 69, and most of the people in those in the higher intensity are older. Okay, and finally, just to pause, you'll see that the colorectal looks similar again, only more greater numbers in the high chronic conditions with an older age group being included in this indicator. Okay, so what does that mean? So ALC strategies must consider multiple populations, including frail seniors in the community, those in long-term care, those who have palliative care needs at the end of the life. Strategies to identify individuals with mental health and addictions must consider those who use relatively little health services. So think about that as well as those who have major encounters. Cancer screening strategies must pay attention to those with little or no contact in the health system. So some who do have contact, but also those who have little to none, and maybe different strategies. And I see the chat is alive. It's going to be hard for me to catch up and get back to it. But I'm glad people are in there, and I will come into it in just a second. I say we look at equity, and we always produce our indicators across equity strata, mostly based on material deprivation. So I'm going to show you here, if we think about these indicators across material deprivation, how does that look across the segments? And I'm going to say that in most population segments, we continue to see a notable gradient where those who live in the most deprived neighborhoods have the lowest level of cancer screening, and the screening rates go up as neighborhood deprivation increases. And it's larger in here than it is, for example, in the ALC indicator, which is less dependent. And you can see the difference, for example, in the low chronic conditions for colorectal screening, just as one example. the screening rates increase from 63% to 74% as you go into neighborhoods with less material deprivation. So as socioeconomic status goes up, so does screening. And we continue to use the material deprivation. So you can see here, this is a three-way graph where the rows, the x-axis, so to speak, talk about the different or identify the different groups in the BC matrix. So the non-users, healthy, all the way up to end of life. And then as you move to the back, you go from the highest to the lowest areas of material deprivation. So the people at the back in the red have the highest socioeconomic status, and you see that their screening rates, here shown for colorectal, are higher than the ones at the front. And there's a pretty direct gradient across most of these segments. A little more or less in some, but it's pretty striking, again, to see that 10% or more difference in the screening rates. This is within people with similar health conditions and needs. So it's not just on the, because of their needs. And people have been asking about primary care models. I've seen it come up a few times in the chat. It was on very early. So we also looked at this across primary care models. And we also notice here that most population segments, we again see a notable gradient where those who are attached to family health teams have higher rates of cancer screening than other capitation models, which are higher themselves than blended payment or non-enrolled patients. Just as an example, mental health and substance abuse segment, in that particular segment, breast cancer screening with mammograms decreased from 69% in family health teams to 31% among those that are rostered only in comprehensive care models or not rostered to a primary care physician at all. So those who are seeing fee-for-service or maybe even only walk-in clinics. And so here you see those results. Again, the red are the fits in the background, family health teams, and then we go to capitated models for family health organizations or networks, family health groups being that kind of turquoise in the middle, and the front two being the fee-for-service models, where we have lower rates of cancer screening. So just to, for us to think now as we're thinking about cQIP indicators, that there are going to be different strategies. In-reach means connecting with the patients you already see a lot. And outreach means considering the barriers to people who are not coming in for care. And maybe thinking about different strategies and reaching patients in primary care practices that do not have rostered patients or primarily fee-for-service. That's going to be more difficult. So how do you do that? And you'll have the indicators in the next month or so, according to these models. I'll say the overall patterns that we're seeing here are replicated in your OHT. The exact degree to which they are varies, and the number of people obviously varies, but these patterns, we put up charts here today that are robust across Ontario health teams. And I think that's the value. Okay, and I'm going to come to the chat now, thinking about your questions or ideas around cQIP indicators. And I hardly even know where to start. Talking about, so unattached, we'll say the fee-for-service patients in our graphs are largely unattached. There is a little bit of a refinement that the Inspired Primary Healthcare Group has done, and we in the future will be looking to replicate that. We couldn't do it in time for today, but pretty well, the people who are attached are mostly done by the fact that they are rostered to a physician, either through a team or capitation or through the comprehensive care model, which allows physicians to keep track of their patients. Okay, and that I think answers some of the questions. Looking at, oh, some people are talking about very specific calculations. My brain is not ready for that at the moment. More unenrolled patients than enrolled due to PCP retirements. And so that will show up for you in your graphs and your Ontario Health team. And that's where there will be some variations in the numbers. Again, the overall picture will be similar. The reports in primary care differentiate the ones affiliated with a family health team versus not. Yes, so if you're affiliated with a family health team, that gets a second a different reporting from the FOs that are not family health teams. So in that prior chart. At the ministry data meeting, yes, we are replicating exactly what the ministry is reporting so that we can be aligned and you can be looking at the same data. Very often in this province, we have different people putting out different indicators and it's just confusing. So we're going to stick to those. The NPC-led clinic currently are not being reported. In the future, there will be more data available through the NPC, and I know that's going ahead. I've been talking a lot, and I see that the people are contributing in here and looking at different ideas, and I think that's great. A number of the questions seem to be related to getting what type of data. You'll see something very similar to the charts that we've run through here, and there will be a few more, and you'll also receive aggregated Excel data files that provide you more opportunities to slice and dice or look at the indicators a bit more refined, also by different segments, by socioeconomic material deprivation quintiles as well. We cannot provide individual level de-identified data or otherwise. Our data come from ICES and the covenants there require. So you are going to be hearing from us starting about the 2nd to 3rd week of February to arrange a meeting. We're not just going to ship these off. And once we've confirmed a meeting, then we will send you the data packs and we will be able to come in and have a conversation about these data. Previously, last spring, we just sent out data without providing any context or real opportunities to talk about it. And so this time we've agreed that we are going to set ourselves up to have a conversation. There are 3 of us at HSPN that could have this conversation. So we are going to, I would say we have a lot of friends. Christina is one of our friends. Some of the other population health coaches are our friends, and they are going to help with having these conversations. And so through various individuals attached to the supports for Ontario health teams, including OHT fellows that are in your OHTs, Ruth, myself, Luke, the pop health coaches, we're gonna all be supporting sharing the data with your OHTs and having a conversation to think about how do you use these. Oftentimes when you see the results in the data, it's like, that's nice, but having the conversation about how to use it or having the chance to ask questions doesn't happen, and it's difficult to do in a forum like right now where we have 289 people online. So we're going to do it in small groups. So that's going to be something that hopefully you will find more valuable. And while it's going to be quite time consuming, we're a small group and there are many OHTs, we're hoping that it provides extra value along the way. So just coming out of this, think about your opportunities for improvement. I see Lori Dunn was just on there, and keep you in the loop regarding the community of practice from Ontario Health. They have change ideas, and I strongly recommend that you look at the resources that are available to you through Ontario Health's cQIP community of practice for these change ideas and the discussions that they've been supporting across Ontario. And I think that's going to be of a great advantage to you. I'm just going to close out here from this high-level aggregate view. Population segmentation into different types of healthcare needs offers more refined information on which individuals require additional intervention. So how to think about which populations you can move to improve your cQIP indicators. You may have a low rate of cQIP, but very few people in that group. And so knowing how many people are in that group is going to be important if you actually want to make a difference at the population level, coming back to where I started this conversation, moving population health, and thinking about different subgroups, perhaps across material deprivation or otherwise, to think about improving equity in these indicators as well. So that's really our focus in supporting your ability to do this work and think about the data These are the data that represent the different indicators in your populations. We will, as soon as we're in contact with you, we'll be sharing out the data. I don't think scheduling a meeting, we won't have to see you in order to share the data, but we do want to make sure that we've got a connection set, so that and then we'll share the data before we actually have a scheduled meeting. So we could set a scheduled meeting in April, in May, and you'll get the data as soon as we put one in the books. We just want to make sure that we actually have something and a shared commitment to talk about the data. So I think, yes, of course, having de-identified individual level data. I'm not sure if there are people online today from the groups that may also have access or be thinking about access to individual level data on the part of Ontario Health Teams. Put me in the group of people that would like to see that happen. Robert Barnett talks about getting some use from IntelliHealth in this regard, and I'm hoping that we are going to have an example coming to this webinar where I've seen people using IntelliHealth in some pretty sophisticated ways to help do this kind of work. So more to come on that. And the other campaign we'll put on is to get an OHT flag put into the IntelliHealth data, which will be a real boon, I think, to being able to do this. This data will be available this week. This slide deck will be up online this week by Friday, along with today's video. I'm going to back off now and turn it over to Christina to let us to understand how does this really work within your OHT. So thanks to all for your interest in this high-level work, but let's see, how does it really feel like at the front lines?
Thanks, Walter. So I'm going to share a few examples that I think are kind of basic and easy for anyone to do. And I know that everyone is at different stages with their segmentation work. So this might feel a little bit repetitive or familiar to you. And so if that is you, I encourage you to share some of the examples of how you're doing segmentation in your own OHT for the benefit of everyone. And I'm going to start out on the next slide by just sort of doing a bit of a level set and a bit of foundations about segmentation, because I always find it helpful to think about purpose when we're talking about segmentation. So segmentation for population health management really is a process of understanding why the health of groups is not optimal. And it does involve using data. And so we've seen a bunch of examples today from HSPN. We've seen lots of OHTs have received the Inspire primary care reports. We heard about teams using IntelliHealth. There's the cQIP data that's coming. Some groups are using IDS. Some are going directly to hospitals to grab data. Some are working with primary care. So there is a lot of data out there. And it's not always organized in a way that's super helpful to us, and it's not often perfect. And that's okay, I think, because part of the process of segmentation is using that data, but also your team, your OHT, and your community's knowledge to really understand how systems, processes, medical care, and patient factors being things like social determinants of health or the material deprivation, health literacy, the presence or absence of caregiver support, how those factors come together to influence an outcome. On the next slide, I talk a little bit about, I really like to talk about segmentation as a process. So it doesn't end when we sort of break up the data into groups. The purpose and the process of segmentation really helps us to challenge our assumptions and act on data and knowledge. So I'm sure many of us have sat in meetings where we're faced with a problem that we've had for a really long time. We've got some ideas for solutions, and maybe we implement that, or maybe it fizzles, and maybe we don't check on whether it actually worked. But this process really is about doing some root cause analysis, really digging into the data to understand and to challenge our assumptions and not just start from a solution perspective. So the process of segmentation supports planning to better match our finite resources to needs. And sometimes we characterize needs as risks. or risks as a proxy for needs, but we still need to dig in and understand the nature of those needs and the variation of those needs. It helps us to identify improvement opportunities. So what we learn about our population can directly influence and inform the care models we use to meet those needs and close any gaps in care. And then to understand and account for variations in populations. So this is something that's come up a lot in the chat. Who are our attached patients? Who's going to nurse practitioner clinics? Who are unattached patients? So even within a segment, there's going to be so much variation in that population. And it's really about understanding that variation and trying to develop care models that will meet the needs of that population. Next slide. I always love a good Yogi Berra quote. I don't often quote anyone from the New York Yankees, but he's got some good zingers. We're lost, but we're making good time. So I think, because there's so many different ways to approach segmentation, whether it's the tools you're using or the scale of the population you're looking at to start, it can be natural to feel lost at times. And maybe if you're lost, you're making good time. I don't know. Either way, the next slide, I've got a few key principles that I think are helpful for carrying out your segmentation effort. And the most important really, I think, is make learning about your population the priority of the effort. There's a lot of different approaches. There's a lot of different data we've talked about to take with segmentation. But I think as long as you make learning about your population to drive or to inform your care model co-design, make that your North Star, you'll stay on the right track. And the data won't be perfect. So use your team, use your community to really inform to really understand what that data means. Look for leverage points in your data. It's not always clear what these are, and it's often tempting to start with the most costly conditions or sometimes the highest burden conditions, and this can be totally fine, but it's also really important to bear in mind that one of the key tenets of population health management and ultimately being clinically and financially accountable for a population is to keep that population healthy and supporting people to manage their chronic conditions. So keeping people healthy is really one of the key leverage points in this work that's connected to higher cost of care, higher morbidity, mortality. So moving upstream can be a really good tactic for finding leverage points. Start small, learn and grow, and improve over time. You really don't need to build the perfect segmentation approach. You don't need to start with the perfect data. Wherever you start is just fine and will help you learn, develop that segmentation approach over time and improve it. And then you can scale it up as well to more of your population. This is kind of connected to the next one, which is don't let perfect be the enemy of good enough. So it's especially true if you're looking around at more advanced systems or looking at OHTs who've been at this for a longer time. Just start small, learn and grow. And then also, of course, steal and share, repeat. Learning networks like this, peers coming together and sharing is really the fastest way to advance some change and innovation. So steal with permission and give credit and share what you're doing and learning with others. And then finally, segmentation is really a process. It's not a single outcome or an endpoint. So it's not something you'll do just once. You'll need to develop the systems. You'll need to develop the workflows to carry this forward and to do this ultimately at maturity for the entire population. Okay, and before I get into the perfect, thanks, Walter. Before I get into the examples, just a final sort of note that there's really no single right way to do population segmentation. Things you might consider are what data you already have available, and you've received a number of data packages, and I know many of you are using different sources of data and leveraging different partners that are coming to your tables, which is great. Thinking about who can come, who can bring data, using sampling, using de-identified data can be a really good place to start if it's what you have. And then segment based on what you already know. So you can use things like quality standards or the quality indicators, the gaps, like those cQIP indicators we saw today. You may know stuff about neighborhoods and demographics. And so just really one of my colleagues and mentors really said to me, At the care team level, the care team often knows who their patients are. And if you're looking to figure out the risk across a panel of patients, they can sit down in 3 hours and decide, who's at high risk, who's sort of rising risk, and do that fairly quickly. So leverage your teams as much as possible. And then think both about low tech options and high tech options. We've seen some of the high tech options like the Kai Pop Health Grouper. I think we've probably talked about the Johns Hopkins ACG system. These are really fancy, sophisticated systems for doing risk stratification and segmentation. And but I don't want to discount that you can just pull an Excel file and start looking at the data and understanding that. You can do a care team review, just like I mentioned. There's lots of low tech options for getting started. Next slide. Okay, so my first example, I know that a lot of OHTs have selected frail older adults or older adults with multiple chronic conditions or mental health disorders for their first year or their priority population, year one population. So thinking about this population, we can think about the whole attributable population, which is quite varied. And I've got the Kaiser risk pyramid there to show that. And so now if we're thinking about, our older adult population, maybe we've decided to define this as 65 plus, largely because our team decides the clinical frailty scale has been validated to 65 plus. So we got to start somewhere, so we can start there. So now we've got a subset of the population, all adults 65 plus, and just like our entire attributed population, we know that our older adult population has a mixture of individuals. So we have low risk individuals who are healthy and living in community. We have also rising risk individuals, so older adults that may have one or more chronic condition that are maybe well managed. They're probably doing fairly well, but they are at rising risk. So we want to make sure they're staying well. We also have medically complex, high risk individuals. So they may have multiple chronic conditions. Maybe they're not well managed. They may be in higher levels of care already, so not living in community, or they may be in community and experiencing hospitalizations due to falls or exacerbations of chronic illness. Excuse me, they could also be in hospital waiting for an alternate level of care. And then, of course, there's a highest risk or highest user groups, which are probably needing palliative care and at end of life. So when it comes to this population, a lot of teams are thinking about some of the corresponding downstream indicators like ALC days, preventable ED admissions, falls-related admissions. The next slide. So what moves can we make to move upstream? And some teams are thinking about this in terms of how do we best identify and manage frailty in community before a crisis occurs. So starting with a problem that's similar to that, we could use a pathway like engage to understand our problem better. And by engage, I mean engage with the community, look at the data that we have, as imperfect as it may be, work with the partners that we have at the table. So things you could do at this stage are validate with data and observations. Use something like a fishbone diagram, which I'll share an example of. We could use process mapping. We could use a Pareto analysis. So there's a number of different tools that we could use to try to understand the problem a little bit better and start thinking about what we could do next. After that, we want to be thinking about gathering change concepts and ideas to close these gaps to fix this problem. So best practices, maybe from other OHTs, from literature. What do our patient, family, friend, caregivers have in terms of ideas, and how are we co-designing with them? Using that problem analysis from the previous step to drive some of the ideas. And then, of course, Walter also talked about the Ontario Health Quality change ideas that exist. So there's lots of different quality change concepts that can be used that are sort of just universal that could shape some of your thinking about a care model. And then finally, and I'm not going to talk a lot about the testing and implementation. I'm just still back on the other slide for a sec. Perfect. Testing and implementing changes. So using small tests of change, PDSAs, to scale up our tests of change over time rather than sort of a big scale implementation. We want to test it out and see how it works. So let's go to that fishbone diagram. So this is just to provide a bit of an example. And I know there are a number of OHTs who have been using fishbone diagrams to do some root cause or problem analysis. Here's an example that's just sort of a concise example to share. So here the problem is frailty is not identified and managed before crisis. And we want to think about this, again, from some of those patient level issues, system issues, medical management or provider issues, and process issues. So examples at the patient level could be maybe the patient doesn't have adequate transportation, or they're having issues getting there, or maybe there's health literacy or language issues. Maybe they are unattached or don't have a regular primary care provider. At the system, maybe there's no frailty case finding or documentation of standard process in place. There's no team-based care to support this process. At the process level, there's no pre-visit planning, nowhere to record frailty in the EMR, which is in doing some work in primary care on frailty, that's something that came up quite a bit. And then with medical management, perhaps limited knowledge of frailty care management, no focus on self-management support. So those are just some examples of how to be thinking about moving from the data and potentially imperfect data and thinking from at the community level, engaging your team and your community to think through what's sort of driving this problem. Next question, and the next one's going to be a poll. So we can launch this poll. And I'm just curious, based on doing a process like that, so we've arrived at sort of, we've got our population that we're thinking about, and now we're thinking about trying to understand the population using data, but also our team. Where might you go next? So prioritize root causes, begin brainstorming some solutions, implement a best practice program, or maybe something else. And if it's something else, please go ahead and share it in the chat.
I'm not sure if you can see it for sure, but we have about passing 50 people have responded so far. So we're going to keep this open for a little bit and let people have an idea.
Hi. Let's see it. What do you guys think are your next steps?
Looks like prioritizing root causes is a little bit of a leader.
Okay.
Brainstorming coming second, but people are still definitely coming in, entering their ideas.
Good. And if there's anything else, go ahead and share it in the chat. I'm seeing ask for data that can be used to further understand the issues. Yeah, absolutely.
Okay, the poll's slowing down, so I'm going to end it and share it back out with everybody. So 67% of the people that responded prioritized root causes, 37 saying begin brainstorming solutions, 12% saying implementing a best practice program, and then just a few people with the something else. And I see a few more chats coming in now.
So engagement of communities to identify gaps, that's a great idea, and definitely a really important principle in care model co-design. Uh-oh, I just lost my the share screen, but I know that prioritize root causes came out as number one. Begin brainstorming solutions. And those are two of the things probably in some of my work that have come up most commonly as well. And then implement a best practice solution. The only thing I'd caution is that you make sure you test as you go using those small scale tests of change rather than the big implementation, which is just really good for introducing change and for minimizing risks upon implementation. Okay, thanks so much. I have one more poll question. Okay, and I'm just curious to learn a little bit more for those that are actively working on segmentation. Are you using some of these tools like a fishbone diagram, a Pareto analysis, process mapping, something else? Positive deviance is sometimes something that will come up. Positive deviance is when you look for some of those bright spot outliers, patients that are doing well, and what are the reasons that they're doing well that you might not expect. And Pareto analysis, the 80-20 rule. So 80% of the things cause 20% of the problems. Yeah, that's it. Or 20% of the things cause 80% of the problems. That's it. So you're looking for what are all the causes to the problems and then ranking them. How are we doing, Walter?
Yeah, so we have about almost 50 people in now. We'll leave it up for maybe about 10 or 15 more seconds, and
okay, I'm
a
just
little
gonna
more Yeah, and something else, please share those other ideas in the chat for the few people that are thinking about someone else. And I'll leave it up. Can you take it down now in like 3? Well, I'll share it. 2, 1, and I lost my ability to touch that. Let me see. There we go. And so sharing the results out.
Okay, so I see process mapping is a leader with almost 80%. Fishbone diagram is something people are using. Some folks are using Pareto analysis and something else. So using, looks like in the chat, we've got value stream mapping, co-design ideal patient journeys, and I saw patient journey mapping come up earlier. Let's see, collect, understand patient experience, map it to their journey. Yeah, this is great. I mean, these are all tools, and there's lots of tools that can be used to take whatever data that you have and really understand what's going on in your population. I know many OHTs are already doing this, so really nice to hear about some of your examples and experiences. I would encourage folks to share their fishbone diagrams, process maps, any artifacts that come out of it in the COP community practice. Okay, Walter, let's move to the next example. I just have a few more short examples and then a few more poll questions. Here's one other example. This is based on some work I was doing with some groups in Washington State, but we use diabetes. But what we used to segment the population here and understand it a little bit better was just the clinical care guidelines. And this one I'm using the Ontario Health Quality Standards. So for all people experiencing moderate depression at, say, clinic level, you could do this at a clinic level, you could do this at a PEM level, you could do this at a whole population level, but it just becomes a little bit harder. So I would say that what you could do is start with all the patients you know with moderate depression, so they're diagnosed. And then the next step in the quality standard is, did they receive a comprehensive assessment within 4 weeks of their initial contact? You group all people that didn't receive it, and then you group all people that did receive it. And for those that did, you continue down sort of the pathway to see if the quality standards were met. For the buckets that are red, those are people who didn't meet the quality standards, and that's the source of another fishbone diagram. So what happened there? Why didn't their care meet the quality standard? And looking at that from both the patient issues, the process issues, the system issues, and the medical management issues. Again, that's just another example of segmentation approaches that I've seen. And then I've, next slide, connected that also to a fishbone diagram, which is similarly just moving downstream in that quality standard. Now we're looking at moderate depression and all those folks who aren't responding to treatment. What are some of the things that might be going on with those individuals? Is it maybe a language or literacy issue? Is it an adherence to medication issue? And you can tell from some of these things that you might brainstorm on a fishbone diagram, they could be their very own fishbone diagram. So like adherence to medication, there could be a lot of things going on there. Is the individual unstably housed? Are there other mental health conditions? Is it an access to the medication, a cost? So there's additional things you could dig into for each of those root causes. And then the last example on the next slide is just another example of segmentation. And this is some other work that's happened in the US where they were segmenting their vaccinated population by race to look for equity gaps. And so I know many OHTs have been looking at, you know, what population has no vaccine, one vaccine, two vaccine, that's a booster. You're drilling down to neighborhoods. You're looking at this in different age groups. And here is an example of looking at this by race to look for some of the equity gaps going on. And then again, when we identify those equity gaps, we start looking at understanding the problem better, going to the community and getting their guidance on it. Is it an access issue, resourcing in the community issue? Is it a mistrust issue with the system? So again, just more work, more just viewing segmentation as a process of understanding, using the data, but really drilling down to understand what's going on. Okay, and then the next slide is a poll question. So where are you at with your segmentation efforts? I know there's probably folks from cohort 3, there's cohort 1 and 2, so everyone may be all over the place. And I'm just curious to see where you are in your segmentation efforts, not started, just beginning, or have you completed for your year 1 population? How are we doing with the poll?
I think I just put it up. I'm going to see, Ms. Rat, we might need, yes, thank you. Need you to hit that extra enable button somehow. I don't have that. I'm one step short of full control here.
Is there anything I can do? Am I doing it right?
No, Strat's got it. It's great. Yeah.
Okay, okay, so not started, just beginning, completed for year 1 population. I know some folks are voicing in the chat, which I'm kind of missing a little bit because I'm talking, but that, you know, you don't have the perfect data, you don't have exactly what you would want to do. So maybe there's some low tech or good enough options for now.
Yeah. Rachel's got a great comment in here about needing to build trusting relationships before clinicians will even look at their data and identify ways of improvement. So I think relationships, right? The importance of relationships and building trust. We've found to be fundamental in at all levels.
Yeah, I totally agree with that. And using the quality improvement philosophies of this is not about judgment, this is about learning and improvement. That's really key.
Okay, so sharing out the results, I think you can see them now.
Okay, great. So almost half haven't started. So hopefully there's some examples in here that will help you get started. And there's a community that are working on this and have lots of examples too. So my hope is that you'll be able to connect with individuals who are working on this, just beginning, awesome, and already completed 11%. So that is really fantastic. And we would love for you to be sharing everything that you're doing on the community practice, the forum.
Yeah, absolutely. And also I see that for the community practice, Margaret Willards put some links in the chat so people pick them up.
Perfect.
Be able to join in. We have another poll.
Yes, another poll and then one question. So this one really relates to like how confident you feel in your ability to do segmentation. So I'm just curious on a scale from 0 where you're not confident at all to, or 1, I guess we have, to 10, very confident. How confident are you that you can segment any part of your attributable population?
Great, people are coming in now with their options. And I think, you know, maybe we'll aim for a higher response rate this time. We had pretty good last time, about 50, but even if you aren't directly involved in OHTs in the frontline work, I think everyone here could have a comment on being able to support or get involved in this work. And this is sort of a confidence, oh, and great, we are getting more people clicking in on where they feel their level of confidence in doing this work. A few more coming in, slowing down. I'll leave it up for about 3 more seconds. The last couple people who are handy. And it is going to be a little bit mixed this time. So I think you can see out those results now.
Yeah, a little bit everywhere. Okay.
Just scroll a tiny bit.
Yeah, so for everyone, I would say that is 7 and higher, I really encourage you to share what you're doing and what you know on the forum. For folks that are between 1s and 6s, I also have a follow-up question that I'm curious to see how we can support you to do some of the segmentation. And also for those that have all OHTs have been offered a RISE population health management coach, connect with your coach because they can support your segmentation approach as well. So let's just move to the next question then and dig into that a little bit more, because I would like to know what would help to increase your confidence score that you just put in there as it relates to segmentation. So just let me know in the chat box. Segmentation.
It'd be great to know if people are thinking
Working with our coach.
Excellent.
Great.
Diana Raven Watts.
Access to integrated data, more training, coach, more training. So maybe in the future, some more examples on segmentation might be helpful. More data, always more data.
It's interesting. We've come down here, Christina. Like I'm talking data, and you're talking coaching, and we're hearing the people coming in. I think about halfway. More data, more coaching.
Working with our stakeholders who know the population well. I think that's a really great move. Not sure yet. Our OHT has access to the data we need. Great. So just on a learning journey. More detailed attributed population data. So Walter's going to be sharing those reports soon in February, which will be helpful, I think.
Yeah, and we'll also be coaching along the way and providing examples of people that are using some other tools, such as the IntelliHealth that some people are on here, that they can use themselves to dive in, or through IDS with support from the IDS group as well.
Perfect.
And
well, this has been really helpful for me, and it helps us as coaches too to know where some of the leverage points for us are and places we can help. If you don't know who your coach is, I'm going to drop Mike Heinmarsh, who's our lead coach, into the chat, so you can connect with him if you're looking for who your coach might be.
Yeah, and I see it's coaching at the practice level. So I think it's actually interesting. I wonder with the coaches, when you're out there, it doesn't have to be at the aggregate level. If there's an initiative that teams are interested in working on with particular practices, will you, I think you'd go that route, like if that's going to be their area of action, right, from the OHT.
Like working down, sorry, Walter, I was just trying to find Mike's, that question was for me.
Yeah, I was
sorry, finding okay. Mike's contact.
Yeah, well, I'll let you do that. And when I see it pop up, then we'll.
I think lots of the coaches, if I'm answering your question, lots of the coaches are working with implementation leads, but there's lots of instances where coaches are working on or sitting on some of the committees and working groups that exist. So that's definitely an option as well.
Yeah, and Leslie's put her contact info into the chat.
Oh, perfect. So thanks, Leslie.
Follow up there, which
you
is a great way.
You can see how slow I was.
Yeah, yeah, I think when we've seen really strong examples of population health management and integrated care and good team-based care, and I know some of this work. I know Rob Reed, who's also part of that RISE team in general, worked out at Group Health, where they did a lot of this kind of work. And there was someone there, Ed Wagner, some people may have heard of him. But I remember when we were working on integrated care, I asked Ed, where in the US, because there's so many systems in the US, they had done it, and what really made the difference for teams being able to come together and share, come together in common purpose, shared purpose, and really implement models together. And he did talk about the role of facilitation in teams. And teams eventually had to build in their own capability for facilitation and coaching. So I think, you guys are absolutely doing a brilliant job across the province, but it's a little, you can only have so much time and energy. And when we talked to Northwest London, they had like weekly meetings at the local level with their coaches and facilitation, and bringing and actually reviewing through and helping clinicians to review through their records and talk about which individuals needed more outreach or more follow-up. And that level of facilitation eventually is actually quite important in team-based care. So more than the 4 RISE coaches to cover the entire province of Ontario is probably needed to really do this robustly across the province, I'll say that. And teams can start thinking about who on their teams can support some of this work as well. Just as, enabling access to data is, high priority for us, because we as HSPN, we're on the data side, only have so much capability as well. So I think building up the strengths across OHTs is really our goal. And I think that would be true of your coaching as well. Of course, people looking for a chance to see the slides from today. Do you have anything else you wanted to add there, Christina, before we close off?
No, I think, hopefully my takeaways were that segmentation is a process. It's not an endpoint, and make learning the priority of the effort, and that you don't have to wait for perfect data, because it never comes, quite frankly, to move forward with something right now that will help you learn more about your population and inform your care model co-design. So hopefully this was helpful. Hopefully there were some helpful examples in there. This is a really great community that has lots to share and a huge breadth of knowledge. So I think we're in the right place for folks that are looking for more information for supporting their segmentation. Thank you for having me.
Absolutely. And I like this idea about sharing chat. I think we'll have a quick look through and see, but that might be something that we can make as a resource, because it does appear that there's quite a bit of context and information. And as long as we can do that, I think as long as there's nothing like highly controversial, I think we'll be fine to do that for the people. I want to thank everybody for joining us. We do have one more reminder for people coming up, that we do run this series the fourth Tuesday of the month, every month. So for the 25% of people who joined us for the first time today, sign up again. We really, in the next foreseeable future, see ourselves developing the series through two main streams. One is a series in population health management. I mentioned we had last February, we had September, we have today. Next month, I think we'll also be on population segmentation, thinking about more examples from Ontario health teams that are doing this. Feel free to contact us, actually, if you're doing some of this work yourselves. And then understanding some chronic disease management, I think, throughout the rest of this year, touching perhaps on diabetes amongst other conditions. So more work in this space. And then also a series in learnings from OHT development. Some of you are aware, many of you, that we are doing some work in developmental evaluation with some of the OHT teams. So thinking about bringing that work forward. And also we are about to go to the field with a renewal of our Organizing for Ontario Health Teams survey that every team responded to as soon as they were approved as Ontario Health Teams. Wave 3, just going to be receiving it soon. We're just waiting till people have a tiny bit more space in their lives before we send that out. So that's also anticipated to be going out next month. We put a slight delay on it. It was a real pleasure to be here today. Thank you, Christina. You really made it real. And we had a fantastic audience, lots of chat, and some really good learning, I think, for people to see what each other were doing. I also even saw that some people were sharing contact information back and forth. We won't put that online, but the other pieces we will. Thank you, everybody. And I had a great time. As I said, you're in for a treat if you came out today. And I think this will be available online. The presentation will be available and the video for viewing later, and you can share with those who weren't able to make it. I know there's a lot going on out there. I'm quite blown away. We had almost 300 people here today, Christina. And I think that just really talks about the hunger for both the coaching and the data, and to understand better what to do. Real pleasure. Thanks to everybody. Have a great afternoon.